all chronic diseases. So neurofibromatosis 1, as we know, that autosomal dominant disease. Yeah. Huh? Restart. Started, no? Okay. Okay, so this is the first slide only. So neurofibromatosis 1 in fraction of patients would be treated by new molecule. And neurofibromatosis 1 is autosomal dominant. 50% of them are inherited, 50% de novo. And we know if it is inherited, then 50% of the progeny of the affected parent is going to be affected. So challenge is, if we have 50% of neurofibromatosis running in the families, to detect them because of the variable presentations, undetectable cases, mild manifestations, and clinical variability. And de novo, there's nobody in the family affected, and still you have a case whether this is neurofibromatosis because of variable clinical presentations, and whether that is then plexiform neurofibromatosis, and whether the treatments are applicable. So it would be a clinician's skill to detect these patients from the community. Now, we know that there is it's not going ahead. Slides are not getting ahead. So we have list of clinical features in neurofibromatosis, which I am just displaying here, which everybody knows. 2 or more manifestations in neurofibromatosis, and we can detect. But the treatment requirements nowadays require precise diagnosis by genetics. So if there is a pathogenic variant in neurofibromatosis, then NF1 gene, then we can treat these patients. If nowadays we see many genetic reports, no? So if there are likely pathogenic or variant of uncertain significance, we have to be very sure that this patient is neurofibromatosis type 1 to have an initiate treatment. So I'll just show you. Okay. So these are the clinical features. Clinicians all know, it is all available with us in our on the internet. So nothing that I'm going to show anything different. But what happens with NF1 gene and protein? So this is neurofibromine, is a large multifunctional protein, majoritarily operative in nervous system, and these NF1 gene mutations which cause tumor predisposition syndrome, where precision oncologists like Dr. Jyoti Bajpayee, who is going to present to us, they come into picture, because this neurofibromatosis gene is tumor suppressive gene, and if that is mutated, you have this tumor predisposition syndrome. But to just show you here is a pathway. So why we are more involved into learning these pathways and molecular pathology, that there are so many molecules involved, and there are so many other manifestations or other phenotypes similarly looking in our clinics, and we have to know that which of these genes is mutated, whether it is NF1 or collectively they are known as rasopathies, where Noonan syndrome also comes. So patients walking in, which of these proteins are mutated and how they clinically manifest and how they are treatable. So this is just to show a complete pathway, and the therapies are coming into this, precisely working on that particular pathway. And this meeting today is intended to address plexiform neurofibroma. So there are half of neurofibromatosis 1 may have plexiform neurofibromatosis, half may be detected, half may not be detected, may be detected by MRI, and these are the manifestations which we see in clinic as neurological manifestations. But in clinics we should know phenotypic variants, where genotype is NF1 gene mutation on the report, but phenotypically they have mosaic NF1, they can have NF1 Noonan syndrome, a child walking with short stature, with mild learning disabilities, some cardiovascular manifestations, but actually having mutation in NF1 gene. So it is NF1 Noonan syndrome. Familial spinal neurofibromatosis running in families, just a spinal tumor as neurofibromatosis, it is NF1 gene mutation. So we have to then go back and see if which gene is mutated. Multiple spinal ganglioneuromas, where Dr. Naresh Biana is there today and may guide us that how do they present or whether they are operable, inoperable. Multiple lipomas have been observed. Symptomatic optic glioma, where only ophthalmologists can have these patients, and this encephalocraniocutaneous lipomatosis. And the differential diagnosis genotypically. So phenotypically, they may present different also, and gene may be NF1, but phenotypically looking like neurofibromatosis, some of the other symptoms, but genes may be completely different. So they can come with Proteus syndrome when there is overgrowth of some tissue, but the gene will be different. Noonan syndrome with multiple lentigens. So we have few caffeole, child walking in with learning disabilities, few caffeole spots, child with autism with few caffeole spots, and can be Noonan. So we have to see whether he has short stature, whether he has other manifestations, whether he has just a mild pulmonary stenosis which goes unnoticed because of no clinical manifestations, but the gene mutations are these and not NF1. So he's not fitting into our treatment modalities. The Noonan syndrome, a typical Noonan syndrome, which we have a book picture. Then we have all these syndromes where the genes may be different. And Legius syndrome, nowadays we know that these patients come with intellectual disabilities, mild to moderate, autism and other manifestations. So significance of precise therapies to clinicians in the era of genomics, pharmacogenomics. This paper presents rasopathies, where all these syndromes which I discussed, they come under rasopathies, from pathogenetics to therapies, to just to highlight. So our excellence or our clinical acumen, because of the disease rarity that we just have one patient in few years seen, interpatient phenotypic variability with the same genotype also, lacking knowledge of natural history because it is being modified with the treatment. The patient on treatment may have a different natural history altogether, incomplete knowledge of which chronic clinical manifestations might be treated by postnatal modification of particular drug. So these are the challenges before the clinicians, and the novel therapeutics in rasopathies, whatever molecules are being launched, may be used for non-NF1 rasopathies also in future. So this is the figure from that paper, which shows so many molecules are being launched for cancer therapies nowadays in this similar pathway. And the last line reads that several have been FDA approved for the treatment of cancers, all these molecules, for the treatment of rasopathies, and they can be potentially be used for non-rasopathies in future by modification of this pharmacotherapies. Thank you for joining. We have a short talks by Dr. Jyoti and molecule, how this works, by Pradnya from AstraZeneca, and a small panel discussion. So I request Dr. Pradnya to join us. Thank you for joining today. She is a medical director at AstraZeneca, and she will tell you how this molecule works. You have a presentation.
व्हिडिओ एंडला प्ले करायचा ना, माझा लॅपटॉप कनेक्ट करा. Good afternoon everyone. Thank you for joining in from your busy OPD schedules. So I am Dr. Pradnya. I work as a regional medical advisor with AstraZeneca. So today I'll be discussing about the current and innovative therapies in the management of NF1 with PN, that is plexiform neurofibroma. So ma'am has already given us the description of the disease, and we all know NF1. I'll just brush through these slides because they are already being discussed, and particularly we are going to concentrate today on NF1, that is neurofibromatosis 1, which is the most common variant of the disease, and although it's considered rare disorder, but one of the most common genetic disorders globally. So the incidence rate is about 1 in 3,000 newborns. Now again, this is a global data. Right now we don't have a Indian data regarding it, and so it's very important for each one of us to actually identify these patients and help in forming a patient registries for these patients of the rare diseases. Now we all know NF1 is a tumor predisposition syndrome, that is there will be uncontrolled growth and proliferation of the cells resulting in the tumors. It's a heterogeneous multi-system genetic disorder, that is, it's going to involve all the systems, and it does not depend on the ethnicity or gender. Now the mechanism slide is also being discussed before, but just to brief that neurofibromin, which is present on chromosome 17, the NF1 gene is going to code for neurofibromin, which is a protein. Basically, it's a tumor suppression protein, and when it's functional, it's going to keep the growth of cells in check. Whereas when this tumor suppressor is mutated, it's going to result in uncontrolled growth and proliferation. Next, we do have this pathway which explains the pathophysiology of NF1. It looks a little complicated, but just a minute. So what happens normally is we have a RAS, RAF, MEK, ERK pathway which looks after the growth and differentiation of the cells. Now normally what this normally working neurofibromin is going to do is it's going to convert the activated RAS into its inactive form, and therefore it's going to control the growth and differentiation of the cells. Whereas whenever this is mutated, it's going to result in uncontrolled activation of this RAS, thereby uncontrolled activation of the entire RAF, MEK, ERK pathway, resulting in uncontrolled growth. Now why this is important is so that we'll know how our drug works on this pathway. Now coming to the manifestation, we all know as it's a heterogeneous disorder, the manifestations are going to range right from the non-malignant to malignant features, and few of the non-malignant features which are most commonly seen in clinical practice are the cafe alert macules, which are known as CAMs, then the neurofibromas, Lisch nodules and freckling. Also, the risk of malignancy is about 2 to 5 times higher in these patients. Coming to the diagnostic criteria, now even this has been already discussed. We just need, in case a parent is having, we have a diagnosed case of a parent who is NF1 positive, then in such cases, even one of these diagnostic criteria is met, it's okay. If we don't have a first degree relative, then we need at least 2 criteria to be met. Now the tumors, they can either be low grade or malignant, and the plexiform that we are going to discuss today, it's one of the low grade tumors. Now next, coming to the manifestations of the plexiform neurofibroma. So plexiform is one of the most common and debilitating manifestations of NF1. It's found in about 10 to 15 patients of these NF1 patients. Again, it arises from one or more multiple nerve bundles, and it can be congenital, appears as early as birth, or it can develop rapidly in childhood. Next, since these are highly vascular and growing tumors, they can be disabling, they can cause disfigurement, also functional impairment, resulting on which part is affected. Then also it complicates the possibility of surgery, mostly due to its enormous size and how it involves the tissues surrounding it. And also it carries, we already discussed, it has about 10% risk of transforming into malignancy. Now coming to the treatment of manifestations. Now we all know there is no cure for NF1. However, we can help these patients be managed symptomatically. So depending on where these tumors are forming, or depending on their manifestations, the treatment approach or the specialty which sees these patients also changes. So that is why most of the times these patients are lost to follow-up. Maybe a patient presents to the dermatology department first with cutaneous fibromas, or else the patient may present to a neurologist first with his learning disabilities. So often these patients are lost in the process of follow-up, and that is why we require a multidisciplinary approach in which all the different specialties can look forward to this treating these patients. Now, currently the only treatment option that we had till now was surgery. So surgery by debulking the tumor, of course 100% resection of these tumors is not possible because they involve they are very vascular and they involve the nerves around it. So 100% resection is not possible. However, by debulking the tumor, it helps in lowering the pain and discomfort, then also by lowering the pressure on the surrounding organs. Also it improves the quality of the life, including the aesthetics. Now, what are the risk factors? Now, depending on where this plexiform presents, if it's present on the head neck face, then of course the resection is very difficult or impossible. Then also there is risk of progression of after surgery, that is surgical removal may not always guarantee that the tumor won't grow. Then again, incomplete resection of highly infiltrative tumors, then cardiac arrhythmias, multi-organ dysfunction. So these are all the risk factors which are related to the surgery. Other risks are nerve damage, blood loss, functional impairment, and also there are wound healing abnormalities found post-surgery in these patients. Now this chart here just shows the higher risk of plexiform in younger patients. So right here we have the age of the patients, and here we have the volume of the tumor. As we can see it, in about less than 10 years of these patients, like up to 10 years, the rate of growth of plexiform is very high. So that is why children are more susceptible to rapid growth of the plexiform neurofibromas. So till now, surgery was our only option. There was no cure. However, we now have the first FDA pharmaceutical therapy available. So I'll talk about the drug now. So that is selumetinib. So selumetinib is a oral second generation MEK1 and 2 inhibitor, and it's for the FDA approved for the treatment of NF1 with plexiform neurofibroma. Now coming to the mechanism of action, how it acts is, we have already seen the RAS-RAF MEK-ERK pathway. So selumetinib is going to act here on this MEK right in the pathway, and it's going to inhibit it. As a result, it's going to inhibit the following uncontrolled growth and differentiation of the cells. So next I'll be presenting the data of SPRINT trial, which is a phase 2 trial which was done in the patients of NF1. So in this trial, patients aged between 2 to 18 years were included, and they had NF1 and inoperable plexiform causing morbidity. Now in this trial, inoperability was described as when 100% of the tumor could not be resected. So selumetinib was given. The dose was 25 milligram per meter square. It's given as per the body surface area. It's a continuous 28-day cycle, as in it's given daily, twice a day. And the primary endpoints were complete and partial response rate, and the secondary endpoints were as follows: the confirmed partial and complete response, duration, effect of pain, quality of life, disfigurement, then long-term safety, tolerability, and pharmacodynamics. So I'll just discuss few of the important endpoints. Now first, these are the baseline characteristics. Just to see that the median age of these patients was about 10.2 years. Both male and female were included, and the median target of, or the median plexiform volume was about 487. Now coming to the efficacy parameter, complete response, as in the complete decrease in the tumor volume was not seen in any of these patients. However, partial response, which was defined as 20% reduction in the volume of these tumors from the baseline. So it was seen in about 37 out of these 50 patients. That is around 74% patients showed partial response. Then the confirmed partial response. So confirmed partial response is, we see that the tumor volume has reduced by 20%. However, this response was also found on consecutive follow-up of 3 months. So its confirmed partial response was seen in about 68% of these patients. Durable responses, the decrease in 20% of the tumor volume was seen even after 1 year of therapy. So it was seen in 56% of these patients. Now the median time to initial response was about 8 cycles, that is around 8 months. So it will take around 8 months for the response to be seen, and the best response comes around 16 cycles or 16th month of the therapy. Now this slide shows the target PN and the progression-free survival during selumetinib treatment as compared with the natural history of disease. So right here it shows that at 3 years of follow-up, the progression-free survival was 84% in selumetinib treated group, and it was 15% in the natural history group. So this slide presents 2 of these patients who were a part of this trial. So in the first slide, you can see this is the MRI of the patient who had plexiform Next slide shows the reduction in the tumor volume. As you can see, right from the age of, we have the data from the age of 4 to up to, we can say around 8, the tumor volume went on increasing. After initiation of the therapy, there was around 24.6% decrease in the volume of this tumor. So next, this is the second patient who also presented with a plexiform around his neck. Here also we can see there was a progressive increase in the volume of this tumor. However, after initiation of the therapy, there was around 36.2% decrease in the volume of this tumor. Next also we have the radiographic example of response of one of the patient who was enrolled in our trial. So these are the baseline tumor volumes of these patients, and at data cutoff, that is right at the end of the trial data when it was taken, you can here visibly see that there has been also a reduction in the size of the volume of these tumors. Next, coming to the adverse events. So the most common adverse event that is seen with the drug are GIT related, that is nausea, vomiting. Secondly, they are mostly dermatologically, that is the patients may present with rash, paronychia. So these are the most common adverse effects that these patients have shown. Next, these are the other MEK inhibitors which are right now under trial. However, they are not FDA approved and the trials are still going on. So currently, right now we have about 16 patients overall in India who are being treated for plexiform neurofibroma, and the treatment span has been around 6 to 7 months, and in few coming months we are hoping to get Indian experience too. Right now I do have a video of Dr. Irene Bruno, who is the head of rare disease department pediatrics in Italy, and I'll just play maybe after the panel discussion a 5 to 10 minute video of her patient experience and what happened to the patients after they were. She has a pre and post treatment videos, so I'll share with those. So to summarize today's topic, we had an overview of NF1, how the disease is diagnosed and managed. After all, we saw the treatment modalities, that surgery was the only treatment available. Right now we do have pharmaceutical therapy in the form of selumetinib. It's an oral drug, and also it targets the MEK pathway. So thank you.
Any study has been done after debulking surgery if tumor is very large. So it's just showed in the literature it reduced 20%. Suppose post debulking surgery, if you start with this drug, what are the chances of recurrence, or whether partial debulking has been done and the remaining tumor has been decreased significantly. Whether such kind of study has been done with this.
There is no study as in done, but there has been experience from, like I said, Dr. Irene Bruno has shared one of her patients who she had started the drug post surgery, and it helped in not developing those new, mostly it's seen that mostly on the suture line or suture lines, mostly the plexiforms, they start growing. So she has her own experience that post surgery she began her patient on the drug, and then there had been no regrowth or no increase in the size of the tumors.
What is the cost of the treatment?
So the therapy right now comes in 10 milligram and 25 milligram capsule, that is the strength. So the 10 milligram comes around 3.66 lakh, but right now we have patient assistance program. So the total cost of 4 months goes around 3.66. 4 months.
And doses?
10 milligram and 25 milligram, and it depends on the body surface area of the patient. It's 25 milligram per meter square.
Does this drug have a potential to impact the genetic inheritance?
No, sir.
No.
Since no.
It's a treatment for the index patient.
Yes.
It does not impact the
No.
genetic.
Any side effect or a significant side effect has been seen with this drug?
Most commonly, it's dermatological, as I already discussed, rash, paronychia. get dry skin, they can be managed and restore nausea, vomiting. So these are the most common ones. No long-term side effects have been seen.
Has it been tried only in PN or otherwise also it can be tried?
Otherwise, as in?
In what plexiform?
So it is tried in the plexiform, sir. Same question was I was going to ask. So whether they documented when it was going for plexiform, the other neurofibromatosis, what happened to that, the small neurofibromatosis?
So we do have a trial going on right now.
No, the trial which is done out of India already.
Okay. We have experience from experience sharing we had in which they did describe that even you are asking about the cutaneous neurofibromatosis, right?
Because in the same pathway they are working on plexiform. What
They are
happened
working.
to the all other neurofibromatosis?
Yes, even there was a difference seen with the cutaneous neurofibromas, and right now we have a sprinkle trial going on for trial in the cutaneous neurofibromas. So we are expecting the results soon.
No, but this patient witness was the regression in the other
We don't have that data on this trial, but however we had from the experience sharing from the other doctors who had used this on their patients.
For other kind of patients, they have not published the clinical trial data. So they are working on other than plexiform neurofibromatosis. Which molecules will work?
associated cutaneous also.
Okay. So the difference in
so the experience which the other doctors had who had treated for plexiform, they did observe that it did help in reducing even the cutaneous neurofibromas, but we don't have the data published as of now.
Because this is ultra rare, so for that reason, the systematical analysis is not available. But logically speaking, it should work.
The mean reduction was around 25% in the study that you had shown. So what is the duration of that particular, how many months was that the 25% was achieved?
It takes around 8 months for us to start seeing the response, and it takes about 16 months for the best response to be achieved.
And how long are you supposed to continue it?
Sir, right now we think up to 18 years, because mostly in the adolescent age group we see that the plexiform neurofibromas that grow at a very potential rate. So at least up to 18 years, and trials for the adult patients are going on. The results will come in soon.
Ma'am, can we take the questions afterwards? We will start in the next class. We have just 2 sessions, Dr. Jyoti Vajpayee's talk and panel discussion when we will discuss community application. So just before you leave, yes, sir. So your inputs, because you have been asking that whether we can have till Dr. Jyoti Vajpayee takes on registry of these patients, because many patients are likely to be missed, many patients have variable clinical presentations. So what are your inputs for Apollo hospitals? That how can we make a registry of these patients through the hospital or clinicians group in Navi, Mumbai and Mumbai?
So 2 things can be done. One thing is across the Apollo group, we can set up a registry, but that also will not capture because the incidence is so rare. So we can involve the associate, like Indian Academy of Pediatrics, or your Association of Physicians of India, and this organization can help set up a registry. Like with Kawasaki disease, I remember the Mumbai branch initiated a registry, and then we before that we have to have certain criteria, clinical diagnostic criteria, have a training session, and then sensitize pediatricians and physicians through APIs and create a registry. That would give us some fair idea, and we have some collection of data, the numbers will have. As such, this is very rare. So unless we know the disease burden, and otherwise it's difficult.
So prevalence, because we haven't studied in India, is 1 in 6,000. Some countries have 1 in 4,000. Half of them are plexiform. Half of them may be symptomatic. So unless we have a registry, we won't be able to know the load of patients which are here.
I agree, but like Sandeep is for almost 30 years in practice. How many plexiform have you seen? Hardly. So I'm not denying that there is disease, but we need to have a registry and quantify the disease.
Thank you.
So now we'll be having our third speaker, Dr. Jyoti Vajpayeee. Ma'am, thank you for joining us. So ma'am is leading the medical and physician oncology department here at Apollo in Navi, Mumbai, and also in the Maharashtra region. She's also the founder of founder General Secretary of the Immunology and Oncology Society of India. I now request ma'am to please start her session. Thank you so much, ma'am.
Thank you very much for the kind introductions, and I'm very thrilled to share this stage with all of you to discuss about this very, some rare situations, and rare cancers are very close to my heart, I would say, and this neurofibromatosis and associated MPNST is one of those. So I will be discussing, because largely about the neurofibromatosis per se and the treatment part, we have had other speakers who covered. So I will discuss what are the challenges which are associated essentially with rare cancers, and how we can tackle these challenges in India and Asia, and when it is any rare cancer, whether it is a sarcoma in general, or if it is an ultra rare, which is like neurofibromatosis associated MPNST. So I will begin here. Can I have a slideshow mode here? Can somebody help? So meanwhile, right, so while he's setting the stage, I would like to discuss about this movie, The Elephant Man. So many of us must have seen this movie, which was actually a commercial success and a critic success as well, and won actually 8 Academy Awards nominations. In this particular movie, forever imprisoned inside a hideous deformed body, the unfortunate Victorian fairground attraction exhibit John Merrick, who was milked for every penny by the sadistic showman Mr. Bites. And the ridiculed and multiply disfigured Merrick crosses paths with the philanthropic physician Travis, who actually helped him in several ways. And towards the end, I'll again discuss about this story. But this very rare disease actually is giving us an analogy when we treat other rare cancers, and especially in neurofibromatosis type 1 with a plexiform fashion, and when there is an association of tumors, this disfigurement and the analogy really fits in. So why it is so challenging to treat rare cancers? And there is a rare disease, and one faces 2 battles, one being the illness itself, which is very catastrophic, and the other living in a world where very few people actually understand what you are up against. And that poses a lot of challenge when there is any rare disease, and especially rare cancers. How can we improve patient source of information about rare cancer, their treatment options, and how to obtain appropriate treatment? Because when they come across, they know that there is very little support available, because as such we gave an incidence of rare cancers 1 in 6,000 at certain different definitions from India and other part of the world. It is 1 in 3,000, but ultimately they are very rare, and because they are very rare, individualistically very little information about diagnostics, treatment, and even support group is available. So we need to improve about the diagnosis of rare cancers, and perhaps the diagnosis can be the longest detective mission in these rare cancers. That is what we come across. And the treatment challenges, so overall health and social costs to treat rare cancers far higher, off-label medicines, problems of reimbursement, insurance issues, legal difficulties, and extra bureaucracy for prescribers. Everything poses a big challenge, because by virtue of being rare, the level 1 evidence in the form of guidelines or randomized evidence is just not available. And then with a limited amount of evidence, if we really want to go over the board to treat in the best interest of a patient, later on there are a couple of issues, including the medico-legal, till the time things go good, they are good. But once things are not good, every other things also haunt the doctors. So these poses a lot of challenges, and not many people become, they take interest or, to treat such rare cancers. Hurdles that discourages the development of new medicines to treat rare cancers. Pharmaceutical companies, there is a big challenge, because again the numbers are very small. They need to invest a lot to get one molecule into the market. And with all those costs, later on the cost of treatment becomes very high, and that again poses a challenge for larger part of the world, which is 70% of it is low and middle income countries like ours, and then again affordability becomes a big issue. So how to navigate these challenges in research? how to attract industry because of these problems, orphan drugs, because these are orphan diseases essentially, and then orphan drugs, when they come, prescribing them becomes a major challenge. Global collaborations are essentially needed because one cannot do it, and if we are having a big global collaborations, like at present we are having a Europe Asia Rare Cancer Mission, and fortunately I am representing India and I am part of it, and we are really trying to make mission statement and improvement which we can bring in every part of the globe with regard to rare cancers. Also EURACAN, which is again another rare cancer group, it is doing a lot of work in rare cancer space. There is Rare Cancer Global Initiative. Again, I am part of this advisory group. So there are bits and pieces. There are work which is happening in and around the world. But I believe we all need to join hands to make a progress in rare cancer segment. Again, because it is very difficult to provide the level of data required to support the use of an unapproved drug on a compassionate use basis. As I said, that doing randomized trial in these rare cancers are very, very difficult. Rather, I would say next to impossible, because the number of patients which we require to do a phase 3 randomized 2-arm trial is practically impossible. Or it will take so many years, then we will not be able to give to many patients the benefit. That's why there is a lot of talk in the guideline committees from ESMO, ASCO, and EURACAN that perhaps we require a separate level of evidence to get approval of any drug, and that is again important. This is one of the slides which is showing our own epidemiology of rare cancers in India and Southeast Asian countries, and this is now published in Lancet group of journals. This is our data, and this shows this first SARC rare cancer study, because there are some similarities in this part of the world with Europe or America, but many disparities also. Our prevalence of cancers as such low, hence rather than the standard rare cancer definition of less than 6 per 100,000 population, a threshold of less than 3 per 100,000 is proposed by us, and it is accepted by the world. There is also a need for histological rare cancer listing in SARC countries and organizational support for research for these forgotten cancers like sarcomas, pregnancy-associated cancers, and many others. About the neurofibromatosis, already everything has been said. I am just showing the glimpses that this is one of the rare and ultra-rare variety of cancer, autosomal dominant inheritance. So again, 50% of the offspring will be affected. This counseling is a very, very important part. Many patients interpret it very differently, and this needs to be emphasized. We need to bridge the gap, and this MAC inhibitors in the form of salumetinib and others are really a promising step. So there is a problem statement, but there is always a solution. Reference networks or centers of expertise needs to be consulted whenever there is a rare or ultra-rare cancer diagnosis. There are hurdles, only few centers exist, and funding is not available to cover the increased cost associated with the organization of these networks. We need to learn to navigate, we need to learn to tame this beast. So conclusions towards the end, rare cancers have not been much investigated because of their low prevalence. That is why epidemiological studies have difficulties in identifying indisputable etiological risk factors. That is the biggest hurdle. The resources to identify and explain rare cancer incidence, explore their etiology, and decide possible methods for prevention, diagnosis, therapies, everything is suboptimal, and leaving patients, specialists, policymakers with limited information. Low prevalence is a main barrier to conduct clinical trials of higher quality to produce a high quality evidence and provides efficient treatments. Therefore, the role of expert advice, precision oncology, or very personalized therapies is very, very important in these cancers. The incidence of rare cancers vary in different parts of the world, so expertise and experience also vary. We need to take into account global collaborations. There is a lot more to be done with many other countries, coming together, joining hands, and enhanced multicentric experimentation on rare cancers will aid in diagnostic accuracy, better treatments, prognosis, and can guide all of us to significant observations about cancer biology. Academia and industry partnership is a must, and I'm glad that this is happening at least in infantile steps. So with this, I will end here. And again, because I started with the Elephant Man, I'm ending with Elephant Man. So towards the end of this movie, many of us, again, I'm sure that must have witnessed, who are the movie buffs like me. So, one evening Bites, which was a show businessman of circus, he again kidnaps Merrick, who was, released by the philanthropist. And he once more started him displaying the Elephant Man with all the ridicule and all the, sadness he had. Finally, with some permutation combinations and means, the Elephant Man could reunize again with Travis and finally could manage to escape, but by the time it was quite late, and Merrick actually was not having any energy left by then, and he finally succumbed to his illness in a very sad manner. This movie ends with a very sad story. And always this question comes in our mind that could there be a better end of this movie? Similarly, also there's a question that could there be a better end or better fate of rare cancers and how to move forward in this space? Perhaps a collaboration at institutional level, national level and global level is a must. And with this thought, I will end here and I'm open to any question. I also want to say that rare cancers are rare when they are individually handled. But when we club together all these rare cancers, they constitute more than 20%, which is equivalent to any common cancers like lung cancer, breast cancer, gynecological or any other. So we should not be shying away from treating rare cancers. Rather, we should take this challenge forward and try to give the best of the care to these patients who unfortunately got into this rare cancers. Thank you very much.
Discussion, please take questions there only. Dr. Jyoti Vajpayee is leading precision oncology here. So apart from rare cancers also, we are collaborating for cancer genomics and precision oncology for cancers because there are many therapies for rare and other cancers also in precision oncology depending on the molecule. So we are soon launching cancer genomic clinic here for precision oncology for various types of cancers. Shilpa is going to moderate few questions for various panelists which you can invite. Meanwhile, Dr. Jyoti, what is the experience in precision oncology in general with precise molecules coming in cancer therapies?
So I think it's a really important question, and I would say that we have made a progress in cancer care from the beginning when it is one size fits all to now where one size doesn't fit at all. And we really need to be personalized in the treatment modality because previously, if I give an example of just a simple breast cancer, it used to be a histological diagnosis of breast cancer, one disease. And we used to treat every patient with similar kind of treatment. Initially surgery predominant, later on radiation come into picture, and then chemotherapies. And for larger part of the time, these were the our armamentarium. And with this kind of approach where one size fits all, couple of patients they get best benefit, couple of patients they are just stabilized, and couple of patients they only get side effects with very minimal benefit. Because while we are treating similar kind of cancer by histology, the host internal milieu is very different. So we need to see that what is the molecular profiling of this particular tumor, in spite of having a similar diagnosis. And also, what is the internal milieu or microenvironment of that host where this tumor is. And it is essentially the interplay between the two which decides how this particular person or the tumor will behave when we give certain kind of treatment. So we have made a progress from there, one histology driven to become the receptor subtypes, and there is a IHC mediated different receptors. So in breast cancer, we found that there are three kind of triple negative, HER2 positive, and ERPR positive. And from there, now we are in an era where we are doing a molecular profiling, we are doing 1,000 genes of panel, and we are finding that what at somatic level this tumor is mounting and what at genetic level this person's internal milieu is having. And depending upon that, when we make fine decision, perhaps it is the best chance of giving cure or at least comfort them when they are having metastatic diseases. So I think this is the way forward, but the only thing we have to cautiously make a move, because right now we are also seeing that there are many times patients are coming with the reports from the labs which are not really having a credibility. So it's very difficult to act upon those reports. So there is essentiality that what tissue you are choosing, what lab you are doing an investigation, and who is reading those reports. That's the most important thing, and interpreting in a right manner. So I believe molecular oncology labs and of course the joint clinics
So I'm doing precision oncology clinics here, and soon we will be having a bioinformatic person also, and with our genetic team also playing their role. I think we can definitely make a difference.
I think that is the model which we are going to present.
Yes. So now we'll be starting a panel discussion on current application and community awareness for NF1. So I request all the panelists to please come on the stage. We'll start with Dr. Naresh Biani sir. Dr. Naresh sir is a pediatric neurosurgeon with Apollo Hospitals. He has 16 years of experience in the field. Dr. Shekhar Patil sir. Sir is also a neurosurgeon with Apollo Hospitals. He also has a lot of experience in the field and has worked with several NF1 cases. Dr. Himika Gupta ma'am. Dr. Himika Gupta is an ocular oncologist and ophthalmic plastic surgeon with special interest in artificial eye and eye care for cancer patients. Dr. Gautam Dethe sir. Dr. Gautam Dethe is dermatologist. He is also working with Apollo Hospitals and Fortis Hospitals, and Jyoti ma'am. So my first question is to Shekhar Patil sir. So with your experience in pediatric and adult neurology both, what are the chances of pickup of plexiform neurofibromas in treatable age group?
So, of course, we do not have our own data, so we can't really comment on that. My practice, unfortunately, we're not really seeing too many of plexiform neurofibromas. Probably even I've worked with the pediatricians also, so we are not also seeing that many in the pediatric age group. So either we are missing them, or probably I have no idea as to why we are actually seeing very less compared to what is the experience in the Western.
So what do you?
I actually am at a loss to explain the reasons why I do not see.
So what do you think? What could be the possible reasons that we are not able to pick up the cases?
So we are seeing PNF, but we are not seeing that many plexiform neurofibromas. That is one. And probably we are also losing out because we do not have a joint care. So we probably are doing it at an individual level. So probably that may be the other reason why we do not have a true incidence. So unless until you actually work together, wherein all the members who are responsible for care of NF condition will probably work together, then only we can actually have our data. So at the moment, like Naresh will be doing more surgical work, and that way it becomes difficult.
My next question is to Naresh sir, as Dr. Shekhar said. So sir, what is your experience for surgical treatment of plexiform neurofibroma? So we have two prototype images also. If you can explain us what would be the surgical management for these cases.
See, the role of surgery is in this plexiform neurofibroma is just deworking. So most of the patients, I have operated 2 of them, and the reason to operate was a cosmetic. It was on the face and the V1 segment of the trigeminal neuralgia, and wanted to get married. So that is how it is. If you ask for a surgeon point of view, it's an item. So having this type of modulatory therapy is a good. No neurosurgeon would like to get in and operate. Sometimes when it is causing a severe compression of the spinal cord, that is when a double shaped neurofibroma is this type of neurofibroma. That is when is a neurosurgeon going to do a decompression. It's not a curative surgery.
So what do you think, which one are operable and which one are inoperable tumors and MPNs, and to which patients we can advise Corsilevo?
The reason to operate in a plexiform patient, what I am discussing is anything that is having the spinal cord compression. Okay, so if you have a compression, that needs to be relieved. Now, the second thing comes in, are we going to do a complete radical surgery? That we are not going to do. Number 3 is that even if I do a deworking surgery, it is going to recur back. So, having this type of a therapy is a big deal. If you ask from a surgeon's point of view. If it is a cosmetic therapy, definitely we do a process.
Cosmetologic therapy, definitely. So my next question is to Dr. Himika ma'am. Ma'am, being an ophthalmologist, what pediatric symptoms and signs parents come with, and what are the ocular manifestations which are very frequent in what we see in office practice?
So I'm basically an eye plastic surgeon. So we see at least one neurofibroma every 2 months and operate 1 per year on an average. So the plexiforms do reach, general plastics and eye plastic people. one side of the face will be enlarged. That leash nodules are not seen like this. That's a textbook picture. Please forget it. किसी को ऐसा leash नहीं दिखता है. Because we are not from Kapoor Khandan, so that's not how our eyes looks. Leash nodules in Indians look very different and very difficult to pick up. But it is a sure shot sign, and leash nodules are dots on the iris, and they will not change anything. Nothing will happen to the vision. The problem areas are the plexiform neurofibromatosis, where the child, one half of the face is enlarged, looks disfigured. Like Madam said, the child, looks like an elephant. Anybody can see that, from a distance, half. So there's a hemi-hypertrophy, and the eyes cannot open because the eyelid is very lax, and they don't get married, like Manish sir said, and we work together on a few cases like that. So those are the things. From vision point, so that is the looks, दूर से कैसा दिख रहा है चेहरा. From vision point of view, there can be optic pathway gliomas, anything from the optic nerve to the brain in that pathway. There can be multiple or single tumors which is going to compromise on the vision. And so, again, the children are very small sometimes. The parents can't say this child can't see nicely from one eye. It's just that there might be some protrusion of the eye called proptosis. And then we feel, why is this happening? And when the image we can come to know. So plexiform will be seen because it's on the skin, and it will be along the trigeminal nerve, right on the face. It is a clinical diagnosis. And an optic pathway glioma is more of a, we check the vision is low and we image. And that's when the radiology, really tells us that this is a neurofibromatosis situation.
My next question is to Dr. Gautam sir. So, many NFL patients who are visiting at your clinic or maybe any dermatologist, they are adult patients. So, in pediatric patients with signs of NF like CAMS or PNs, how will you guide them for treatment, or what is your experience for the counseling per se?
As Sir said, even in my private practice, I have not seen a neuro problem. Just doing post-graduation, and I was attached to municipal corporation. Hardly I seen for that 9 years, maybe at 1 or 2 or 3 cases of neurofibromatosis. So as a dermatologist, we are the first. The first presentation is the CAM, which is seen in the first year of life, and the parents they approach us for a diagnosis. So normally we used to refer as where we used to see a patient with this. So obviously we used to see the criteria, whether it is more than 6 CAMs are there or less than 6 are there, then the diameter which was mentioned in the criteria. That was one thing. Secondly, we normally used to refer to the ophthalmologist immediately to the next, and obviously a pediatrician. So that's the protocol we used to follow. And then a regular follow-up is the most important, because some of these features they develop over years. Like capsular macules can increase over a period as the child grows. Then you have axillary trickling, which can become up to 4 to 5 years. Then you have neurofibromatosis, cutaneous neurofibromatosis, which can occur, start later, like around 4 to 5, but they can grow over a period till 20 years. You can have Irish, which can develop after in adolescence.
I just wanted to ask Dr. Shekhar, because we've been seeing patients with café spots with autism learning disability. So what is the spectrum for pediatricians to deal with these patients, and which patients are for surgery, then plexiform, and which patients are for ophthalmic? So what is your experience altogether for neurofibromatosis and café?
So when we look at the entire spectrum, we will look at the age at which it comes. So your first visit, you are just going to tell them that these are the possibilities that come. Let's say that there is no ASD to it, and then most of them are actually lost to follow. So even if you tell them that you have to keep on periodically assessing them, so sometimes you will see them. So I remember seeing one patient after 10 years. We have seen when he was 1, and now I'm seeing at 10. So what happened for the 9 years, I have no idea. So that is the problem that we are facing. So it means that unless you have a dedicated clinic that they can go to, they are actually lost. So, and most of them actually lose out because if it is an autosomal dominant, then they actually have a much more psychological impact, and then the parent actually knows what the child is going through. Most of them actually do not approach anyone. So even if you have neuroplexiform neurofibromas which are disfiguring, probably they just accept it and move on. So awareness also should be at the other end also, not necessarily on the physician side, even at the patient end. When we come to a specific situation for ASD, the ASD part has to be tackled as what you would do for a regular child with mental disorder. So just having NF probably you're just at a higher risk because that is the group that you would see. But that the approach doesn't change just because of your child has NF.
We have Dr. Vij who leads plastic surgery. Sir, because you are not in the panel, but what is your experience? You have been dealing with this patient because they either approach dermatologists or plastic surgeons. So, particularly plexiform neurofibromatosis and surgically, how do you deal with neurofibromas?
Actually, I'm really surprised when you are saying it's a rare disease.
That is why, sir, I asked you to come, no? Because they only come to go to plastic surgeons. For other people, they are rare diseases.
So in last 4 or 5 years, we have...
So you can have a mic close so that audible on YouTube, yeah.
Last 5-6 years, we have treated more than 10-12 cases a year. And last 30 years, I have done more than 40 cases. Plexiform neurofibrosis.
So, in general, neurofibromas approaching you?
No, just for the cosmetic purpose, plexiform neurofibrosis. And last 15 days back, I have done one. I was showing photographs to Auditorium. Successfully planned. Okay, and most of the cases are facial plexiform neurofibromatosis, as we said, trigeminal, the reason of the trigeminal nerves. And cafe-orange spots, they are coming to us on regular basis, and we are treating with Q-switch laser. Q-switch laser is a combination of Q-switch and the Recosmo, and they disappear like anything in 4-5 seconds. So this is my approach.
So adult patients are coming to you.
Adult patients are coming, not.
So like Dr. Shekhar said, and I would ask Dr. Gautam and Naresh sir also, that we have adult patients where 50% are inherited. So would you like to have genetic diagnosis and screening of those family members and registry so that we can pick up not only plexiform neurofibromatosis for treatment, but subtle or mild manifestations like autism, like learning disabilities, or patients who can be treated for skin manifestations, or Dr. Gautam said that they would be referred to just cosmetic treatment.
If they come to me, certainly I'll try to help.
So I just want to add here, this was really good for cosmetic. Cosmetic things people get worried and they come. But our most important worry is that around 10+% of patients they develop MPNST, which is malignant peripheral nerve sheath tumor. And at times, and rather majority of the times, the course is really very stormy and bad. And till the time this spastic medication is available, the course is very bad because generally chemotherapy doesn't work that great in this kind of tumors. Sarcoma as such is, it's a very heterogeneous in spectrum with 150 histologies under soft tissue sarcomas. These particular varieties of sarcoma, they fall into intermediate to low sensitivity to any chemo, and they have a propensity to recur. And recur in the setting of NF1 association, there is multiple organ system which is getting involved, and very bad course. So that's why we are looking forward for this management very positively in medical oncology community. And essentially, it is a role model, a kind of poster child for precision therapy and precision oncology guided treatment, because these patients can do very well when they are appropriately targeted with this part.
So Naresh sir, so because they are prone for tumors, no? So your patients, or Dr. Gautam, visiting you in pediatrics and having cancers later associated with such rare as an NF1. So our last diagram is to collaborate because they are spreading across all age groups, and patients coming to you in pediatric age group with their family members with NF1, because 50% of patients. So just your last take, sir.
Actually, having a specialized clinic is a way forward. We have clinics and support groups, for hydrocephalus Genomics. So NF is also the same thing. The guideline is the same. The advantage that we have got is that I can refer to one point person and that is taking care of the whole umbrella. Which child requires an autonomic consultation or which child requires a neurological consultation. So what you are telling is absolutely great and that should be the way forward.
Anything anybody can wants to add or any questions? And thank you, Ved sir, for your take because we've been operating these patients and that is their main concern, cosmetic, yes?
Yes. Basically, when we were doing our post-graduation, Gautam and I belong to the same institute, SINE, and we used to have a genodermatosis clinic, where we used to have a, so what happens is, that is what happens, it just gets stuck the moment the people move out, it doesn't carry forward. If it does carry forward, because we used to have collaboration with pediatrics, we used to have the plastic surgeon, everywhere in that genodermatosis clinic, we used to have patients and we would cover it up there. Now, this is where we can do it here in this sense because we here are having a similar kind of a multi-specialty setup. So here is where you can take it forward and maybe now the things are better. I'm talking about 30 years ago, 29, 28 years ago when we were doing our PG. So that time maybe it was like things would be in registers and all, So now things are data, everything can be kept in and we can move ahead with this kind of registry also.
And because skin biopsies are coming down, like liver biopsies, like muscle biopsies, we are directly going for genetic diagnosis. So similarly for genodermatosis, first is genetic diagnosis rather than invasive skin biopsies. Yes.
Right. Yeah.
Thank you all the panelists for this short, quick discussion. Thank you, Mr. Manoj and Pradnya for coming over and giving the drug information. Thank you, attendees and YouTube attendees for attending today's session. We look forward to have this neurofibromatosis clinic and registry from Apollo Genomic Institutes and our specialties from Apollo Hospital to make more of community awareness and patients, finding out patients for treatment for this disease where this novel treatment is now available. Thank you all.
Manoj.